All right. Again, welcome everybody. This is your 2025 update for telehealth policy from the Great Plains Telehealth Resource and Assistance Center. My name is Jonathan Neufeld. I am a clinical psychologist by training, and I am the director of the Great Plains Telehealth Resource and Assistance Center. My assistant director, Mary, is on vacation, actually, watching a big basketball tournament in the Midwest. I probably shouldn't tell on her. Anyway, she's having a great time, and so I'm flying solo today. But nonetheless, I've got lots of great technical support here from the good folks at Zoom Webinar and the University of Minnesota and wherever else. All right, so let me just take a minute or two to introduce GP Track for those of you who don't know, and then we'll dive right in to a policy update. I think we should be able to get through this fairly quickly and leave some time for questions. Leave some time for questions at the end. So I'm going to go ahead and share my screen. All right. The first thing to note is that we are doing this telehealth policy update for 2025. And we're doing it now in March. And the reason that's a challenge is because this might be, we'll be talking about some things today that might change in the shortest amount of time ever for a telehealth policy update. By Friday, we will know whether or not the continuing resolution has passed, which has some telehealth extensions in it, or not. There is a competing CR that has a shorter time period, but regardless of how that all pans out, something's going to change this week. But nevertheless, there are some things that are permanent, so we'll talk about those and hopefully give you a better sense of what exactly could happen, or at least what's at risk of happening this Friday. As I said before, Great Plains Telehealth Resource and Assistance Center, GP Track, is hosted at the University of Minnesota in the Institute for Health Informatics, where we've been for years now, over a decade. And we are funded by HRSA within HHS to provide technical assistance and training to answer questions about telehealth for organizations of all kinds all across our region. We have a 6-state region there at the top, those green states with the Minnesota in the middle and all the states surrounding, including the good state of South Dakota, the great state, I guess, of South Dakota, we're supposed to say. As you can see, there are telehealth resource centers across the country. All of them do policy updates like this, or at least can provide policy information, even if they don't do a formal webinar. And you can reach all of those telehealth resource centers through the link at the top, the orange link, telehealthresourcecenter.org or telehealthresourcecenters.org. We have both domains. But the best way to contact us is directly. Call us, email us, tell us what you want. Let us help you find the information you need. Let us specifically tailor the information for you and consult with you on your specific project. I'm going to say this multiple times, almost everything we do is free. In fact, I could say everything we do is free except our conference, which I'll talk about later. We, like most of the TRCs, maintain policy pages on our website, gptrack.org. This is the page for South Dakota /South-Dakota. You can see the link at the top there. And we maintain policies for telehealth, as well as a billing guide there. You can see on the right, you have to click through to get to that, and a one-page sort of summary of policies for telehealth in South Dakota. So please make use of those things. That's what they're there for. And let us know if you find any discrepancies, if you find anything's missing, because it is our job to keep those things up to date. Just the learning objectives are pretty simple here. We're going to talk about policy, and you're going to be able to understand what drives what the layers of policy are and how you need to be ready for what's coming at the end of the month, and also what you don't need to be ready for necessarily because it's permanent now. And we'll talk about that from the state level and the federal level, as well as just giving you a quick overview of the structure, a review of the structure of telehealth regulation. All right. So that framework, there are layers of this. And if you're in healthcare and you know anything about telehealth, you probably already know this. It's not a big deal. But just to set the table for everybody, what's legal in telehealth is not the same as what's reimbursable. Okay. What's legal in telehealth is not changing at the end of this month. In fact, I don't see any significant changes in what's legal outside prescribing, which we'll talk about at the end of this webinar, because it's fairly stable and has been for a long time. What you can do in telehealth is basically the same as what you can do according to your license, whatever your license is, because telehealth is regulated through the licenses of the practitioners outside of a few things like prescribing. What's reimbursable is different. Now, both of these things, the legal and the reimbursable, have layers at the federal and the state level. So you have to be aware of how those layers interact. For example, what's legal via telehealth at the federal level is only restricted by a few laws. Basically, the laws that cover healthcare also cover telehealth because it is also healthcare, part of healthcare. So Stark Law, Anti-Kickback Law, False Claims Act. I mean, all the things you can't do if you're a healthcare provider, you also can't do under telehealth. Okay, that's pretty straightforward, pretty simple to recognize. Also, regulations that apply to healthcare also apply to telehealth. HIPAA, for example, is a good example. One of the few real specific laws about telehealth is the Ryan-Haight Act. Again, we'll say a little more about this later, but it simply says that in order to prescribe a medication, a controlled substance, you have to have seen the patient in person. You have to have done an in-person evaluation of the patient before you can prescribe any medication. Now, that's what the law says. Then there's a bunch of exceptions. And of course, we operate within those exceptions all the time. Right now, there are some flexibilities to those exceptions, which we'll get into a little later. Beyond that, or outside the federal level, at the state level is where telehealth is regulated as far as what you can and can't do. And like I said, your state licensure board tells you what the limits are, and most of them align to a federal society, healthcare medical society or behavioral health society, like the like the American Psychological Association or the National Association of Social Workers, or whatever their guidelines are. Most states just refer to those as well. And that's where you're really regulated as to what you can and can't do. So what's reimbursable by telehealth is, of course, a different set of layers because it's payer by payer by payer. And those policies can vary at the national level for Medicare, at the state level, of course, in Medicaid, and then commercial, it's plan by plan by plan. I mean, it multiplies as the closer you get to local commercial plans, those layers sort of multiply. So we have to keep an eye on all those things. All right. All that said, we know what's legal, we know what's reimbursable, and how the reimbursable is fractured and can change. What are we talking about for 2025? Well, it's important to recognize that not everything that we do in telehealth, in fact, most of what we do in telehealth is not at risk. It is not. It started out, there were a lot of flexibilities that were created. I'm going to stay here for a sec. There were a lot of flexibilities that were created during the pandemic, but a lot of those have been made permanent. There are only some things that are at risk of going away. It's not insignificant. It's significant, but it's not everything. So let's dig into that a little bit. First of all, let's take a look at South Dakota. What's South Dakota been up to? Well, the folks in the legislature have been busy the last year, and they made a few changes, some significant, but mostly small things. Nothing that's really going to change much of what you do unless you rely on a licensure compact. One of the things that the South Dakota legislature did is passed laws for all of the licensure compacts except the speech language pathology one. So social workers, PT, OT, psychologists, the medical licensure compact, they've been in for a while. So all those compacts are active in South Dakota to the extent that they're active across the country. I think a couple of them are still planning to go activate this year. But that's one thing that's different in South Dakota this year. There was also a specific law around audiologists using telehealth, even though they haven't signed into the SLP compact. Audiologists can use telehealth, and then they updated a few sections of the provider manual to include audiologists, of course, but also a few other kinds of provider types. These are, I mean, if you're one of them, you don't feel like you're fringe or you're a corner case, but these are provider types that have relatively smaller numbers, and they're just kind of the Medicaid is realizing, oh yeah, those folks can work by telehealth too. Most specifically this past year, behavioral analysts and their assistants and associates in the behavioral analysis domain, which is often used in educational settings, school settings, those folks can work by telehealth as well. So, and then there are a few other kind of little editing changes to the provider manual. It's been updated. One of the most significant changes also is that RPM is now permanently covered by Medicaid. There are links to all of these. This page also has more specific links to all of the laws if you want to check into those, or the telemedicine and audio-only services portion of the manual at that link. There's also, in addition to adding a few new providers, there's also a handy new lookup tool for your CPT codes for your services. And you can decide, you can find out, look them up on the tool, find out whether they're covered by Medicaid or not in South Dakota. So very handy. Kudos to the folks who brought that about, who made that happen for all of you, for all of us who work in the domain of telehealth. It really gives the impression that South Dakota is making an effort to say, you know what, we're gonna make sure folks have access to healthcare via telehealth. In a lot of reasonable and common sense kind of ways. So that's my own opinion, but it does look like there have been movements made, and it does look like South Dakota is moving in that direction. All right, federal updates. Quick review. There were 3 things that flexed in the pandemic: Medicare, HIPAA, and the DEA. HIPAA went away. The HIPAA flexibilities went away right at the end of the public health emergency. DEA said they were going to go away, but then they said, no, okay. We'll leave the flexibilities in place. And then there was a couple of extensions of that till now. The Medicare flexibilities are still in place, and the DEA flexibilities have been extended a couple times, so that now the DEA is extended through the end of this year. And the Medicare flexibilities are extended until the end of this month. So that's where we are right now. At the end of March, what is actually at risk if Congress doesn't get a CR? I mean, I'll say the CR, although a CR is not necessarily always the vehicle for this, but it looks like the CR is the only thing that's going to go through Congress between now and the end of March. And so, assuming that the telehealth flexibilities are a rider on the CR as the vehicle, that's just kind of what we're assuming at this point. So what could happen? First of all, behavioral health services under Medicare. First of all, it's all Medicare. All right. I'll talk a little more about this in the next few slides, but it's all Medicare. And behavioral health services have already been made permanent. So what we're talking about that's at risk is medical care paid for by Medicare via telehealth. Okay, that's the category, the broad category we're talking about. Specifically, the original Medicare rules that go into effect if the flexibilities expire say that the patient has to be at a facility in a rural area. So the patient has to go into some sort of a clinic or doctor's office or somewhere in order to use telehealth. And that facility they go into, doctor's office, emergency room, hospital, whatever, outpatient clinic, it has to be located in a rural area. Otherwise, Medicare is not going to pay for medical care by telehealth. They also in the original rule, this goes back to 1996, 97, only allow live video. So well, not all, again, we'll talk about this a little more, but medical care, audio only care for medical conditions, medical providers could go away. Okay, that's what's at risk. There also are a number of providers that are being flexed into Medicare right now, including most notably FQHCs and RHCs. They were excluded from the original rules that would go back into effect. So that's a big one. And a number of other providers, PTs, OTs, and speech language pathologists also have been flexed in at this point, and that would go away. We'd be back to physicians, NPs and PAs, clinical psychologists, clinical social workers, the original OG gang. A couple of other services, specific programs were flexed in at the beginning of the PHE that would go away, and that is acute care hospital at home program, hospice recertifications via video, annual in-person visits, and a number of other visits that have kind of been flexed in would go away. Now, a number of screening and other visits have also been made permanent in the meantime. So it's not a lot that would be lost in those categories outside those specific acute care, hospital at home, and hospice research and annual visits. Oh, the other thing is that Medicare in the meantime had required in-person visits for behavioral health services, one within the last 6 months before starting and one every year after. That has never gone into effect. It's been flexed ever since it was a rule, but it could actually become an active rule after March 31st if the flexibilities aren't extended. All right. Some things are already gone. I might have mentioned. No, I guess I didn't. First dollar telehealth coverage for high deductible health plans and health savings accounts. It's a little flexibility that if you've got one of those plans that allows you to apply it toward telehealth services during the part of the year that you're using your HSA or your deductible. And then there are cardiac and pulmonary rehab services were allowed during the PHE, and they're already gone. A few things have already been made permanent. So we're just kind of reviewing this too, and you probably have heard this already. You've been doing these things perhaps, but you're doing them not because they're flexible, because they're under the flexibilities, but because in the meantime, CMS made them permanent. Remember, this is all Medicare, all Medicare. There were some changes, obviously, in South Dakota Medicaid, but everything we're talking about now is Medicare. All these flexibilities were Medicare. Behavioral health services within Medicare permanently, on a permanent basis, can be provided from anywhere. That means the patient's home, from a non-rural location, urban locations. It's not a good idea, but if they're in the parking lot at McDonald's or Starbucks, I mean, anywhere. That counts as the patient's residence, by the way. At least in the opinions that I'm aware of. They also can be provided using any secure technology, which any means audio or video. Okay. Audio only was specifically ruled out in the original rules, like I said, but it's now become part of the standard definition of telehealth services under Medicare. So audio only services are telehealth for Medicare now, as long as the flexibilities are in place or they're made permanent. FQHCs and RHCs can be reimbursed and get payment for behavioral health services the same as in-person care. That's been made permanent. So for FQHCs and for anyone providing behavioral health services, those services are permanent and are not going away. All right. So there's for anyone doing behavioral health, video, audio, that's permanent under Medicare. And specifically for FQHCs and RHCs, they get that same treatment under Medicare, and they get their prospective payment or all-inclusive rate for those services. All right. Just taking a little closer look or zeroing in on where these policy changes are coming from. I think I said this already. It's probably just a review. We're not talking about the state at all. We're not even really talking about CMS. CMS has made a bunch of things permanent. We're just talking about Congress. And the things that CMS, the things that are already in the laws that Congress has to act to change. Congress is the only institution that can change laws. CMS can't do it. The president can't do it. Nobody can just make it so. Congress has to change the law. So that's what we're talking about. And to zoom in a little further, among all your payers, you got all the other commercial and every other payer, you got Medicaid, you got Medicare. Medicare is the only one we're talking about. That's the only payer we're talking about. And to zoom in even further, if you divide Medicare into medical care and behavioral health care, we're really only talking about the medical care. Now, it's significant still significant, but I just want to put it in the context. You've got a whole panel of a payer mix across your panel. Medical care paid for by Medicare is what's at risk at the end of this month. Okay. Medicare Advantage is kind of up in the air. We're not sure. It could be, we haven't gotten clarity as far as are they going to be regulated as a commercial plan? Because they are commercial plans that get paid for by Medicare. But sometimes payers say, oh, no, it's a Medicare plan, so we just follow Medicare. And I have heard people say, you know what, if those Medicare standard fee-for-service Medicare coverages go away, those Medicare Advantage plans are going to do the same thing. They're going to deny those services as well. So it is something to be aware of. And it's the reason why so many organizations are basically saying we're not going to schedule any telehealth encounters for the first couple weeks of April, just to be sure. And by the way, if you haven't already been thinking about that, you probably should. If the flexibilities go away, we will have to be concerned about a number of things that we haven't been concerned about for 5 years. Most significantly, whether you're in a rural location or not. This used to be something that we put up at every telehealth reimbursement webinar. We haven't had to worry about it for 5 years. Now we're back. And so I just want to add this link. There is a link where you can type in a street address for a clinic location where the patient is when they're accessing care. And this website will tell you whether or not it qualifies as an originating site for Medicare. Okay. You'll need to use that if these flexibilities don't get extended. I specifically put in, there's another website that says it's at ruralhealthinfo.org, Am I Rural? Some of you have used the Am I Rural tool. That is really targeted toward grant applications and a number of other government-related functions that you need a rural designation for. But believe it or not, there are many different ways of counting whether you're rural or not. That site tries to support a range of them and tell you, hey, according to this standard, you're rural, but not according to this standard, or this one, you've got a rating of 6 or a RUCA code of this or that. It tries to do a lot of things at Am I Rural? So, and the Medicare originating site is in there, but it's confusing, and I don't want you to have to work for it. Go to the top link there. That's the one that only does one thing. Tells you whether you're an eligible originating site at Medicare. The slides are coming. Everyone will get the slides. So, so you'll be able, and these are live links in the slides, so you can use them. All right. All right. The Medicare physician fee schedule is the mechanism by which Medicare makes changes every year. We had one that went into effect January 1. They added a few things. I've mentioned a few of them, though I haven't tagged them specifically to the physician fee schedule. But here are a few things that are in the physician fee schedule. And that means they're permanent as Medicare, regulations can be. Obviously, Medicare can change them down the road, but Medicare has been going in a certain direction for a long time, and it's unlikely that they're going to change these significantly. For one, audio only is a valid means of providing telehealth services if the patient is at home. This is a little tricky. They're threading a needle here. They're saying it's a valid way to provide services if the patient is at home it doesn't say anything about what kind of services, because medical services could be going away at the end of the month, or are not permanent yet. Behavioral health, they're permanent, so no worries. But the only place that Medicare has said audio only is permanently a kind of telehealth, without saying whether it's covered or not, is when the patient is at home. And a couple of things have to be in effect. One, the provider has to be capable of providing both audio and or video. In other words, there's no just phone healthcare service. There, you have to be set up to provide video. If the patient can't or doesn't want to use video, they can all, whatever. If for whatever reason you have to fall back to audio, then okay, you can use audio. But you can't only be capable of audio. You have to be capable of video or audio. And then if the patient says, no, 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 can't get there today, don't have a laptop, don't have broadband, don't have whatever, connection's bad, please call me over the phone, then fine. They tell you how to bill it with a 93 modifier or FQ if you're at an FQHC, and place of service 10. Place of service 10 is the patient's home, right? That's where services are happening. You don't need any other specific documentation, I mean, other than what you would normally provide for a telehealth encounter: start and stop time, patient's location, provider's location, consent, all of those kinds of things. But because they have made CMS has made audio only a part of the definition of interactive telecommunications system. That now is a way that we can provide telehealth. For this year, CMS has also left all of the quote unquote provisional telehealth codes intact. In other words, they have a bunch of codes that are permanent. They have a bunch of codes that are provisional, or they're on their way to becoming permanent. And they haven't removed any of them. They just wanted you to know everything you could do last year, you can continue to do this year. It's all those codes are still intact, including all the codes for audiologists, SLP services needed by those providers. They're not part of the permanent set, but they're in temporarily. If, of course, coverage for those providers goes away, then those codes, they're still in there, but they're not going to be used. The provider has to be, a covered provider under telehealth. A few new codes were added, as they always do every year, including PrEP and some caregiver training, safety planning interventions. As I said before, there's a number of screenings and little patient education, psychoeducation, and medical education kinds of things that can be done over video. Those are all still in there. And there's a link here at the bottom to what's called Table 12 and the final PFS. It lists all those. CMS keeps a list of all these. You can look it up. You can just Google, CMS telehealth coverage list, and you'll get a spreadsheet. They put a spreadsheet up every year that includes all these codes, so you can access that. Another thing that changed this year is the AMA, the American Medical Association, is actually the copyright holder, the owner of CPT codes. All right, little source of revenue, keeps them afloat. And the AMA has decided that telehealth, virtual care is here to stay. We need better codes to cover it. And so the AMA released a bunch of 17 specific new telehealth codes this year. But most of them are like telephone codes and other kinds of specific services that can be provided by telehealth. CMS isn't quite ready to adopt them all. Because CMS and the AMA don't always line up exactly. CMS says we're going to cover and pay for these certain codes. They don't pay for everything in the CPT book. I don't know if you've found this, but it's true. You can code for things, and it's legal to provide things, and you can even provide a CPT compliant service and put a code on it, but still Medicare is not going to pay for it if it's not on a list of things Medicare covers. Okay, so we know that. In the past, for the virtual check-in, what's called the virtual check-in, it's a 5 to 15 minute phone call with the provider, phone or video, with a patient, initiated by the patient. In other words, the patient is asking for a service, and it doesn't lead to a service in the next few days, and it isn't a follow-up from a service up to a week ago. Okay, so it has to be an independent service. The patient is calling up and saying, hey, is this a thing? Do I need to come in and see you? Or I'm feeling this way? Or, hey, I got this thing that just happened. Can you check it out? Anyway, and if they end up coming in the office, then you don't bill the phone call. It's just paid for as part of the office visit. But if they don't come into the office and that's just a standalone consultation, you can bill it as a brief virtual check-in. And that had a G code last year. Now it has a CPT code. AMA, just one of those 17 codes, covers that exact service. And Medicare said, great, we'll use the CPT code. We can retire the G code. G codes are often used for temporary things or new kind of services, things that CMS wants to cover or a payer wants to cover that that don't quite align with an existing AMA code. Just a side note here, 98016 is not a quote unquote telehealth code. And this is a little obscure. If you don't quite get this, don't worry about it. But Medicare defines certain things as telehealth and subject to the 1997 telehealth rules and the flexibilities and all of that. And then there are other things that are virtual care, but they're not technically telehealth for Medicare. Okay. This is one of those things. This virtual check-in is not a telehealth code for Medicare. Excuse me. So it doesn't expire. This doesn't go away. This doesn't change. You can do medical care. You can do these virtual check-ins for in medical clinics for medical providers, and they won't be changing anytime soon. They are permanent CMS policy. But they also don't pay very well. So they're not being used very widely. I don't remember what the exact reimbursement is, but it's $20 more or less, maybe less. So it's out there, but like I said, not terribly popular. The telephone E&M codes last year, CMS said, hey, we're going to make these part of the covered telehealth codes. And this year they went back because they were deleted by the AMA. AMA released a bunch of new codes, said, we're going to use these. We're not going to use those 9944123 telephone E&M codes anymore. So that's another, the CMS and AMA, they don't always, line up. AMA said all of a sudden, hey, those codes are gone. Need that space for other codes. And so CMS said, well, yeah, fine, whatever. These codes will now be paid as a bundled service, i.e. not paid, okay? But the reality is there are other ways to bill an audio-only E&M service, at least while the flexibilities are in place. 9921, 3, 4, 2, 5, those E&M codes with a modifier 93, that's an audio-only E&M code. That's the way you would bill that. So in a sense, those codes were redundant and so not really needed. I'll talk a little more about this in a minute because there is a special code that FQHCs have access to in case that goes away. Visit frequency limits have been flexed since the beginning of PHE, and CMS continues to flex those. You can do as many of these subsequent inpatient visits a week as you need, subsequent nursing facility visits, critical care consultations, they're not limited. And so that remains in place. It's one of the things that happened temporarily during the pandemic, and now this is more or less a permanent policy, or at least CMS is saying we're gonna stick with that for now, for the time being. This is a big one that happened last year and is now made permanent. Again, I use permanent in quotes, because policies change, but live video for direct supervision. The requirement to be immediately available in most cases that for incident 2 kinds of billing, for immediately available supervision services, live video counts. If you're immediately available via live video for the supervising provider to intervene, help out. So that's, again, part of the physician fee schedule, permanent Medicare policy. Also, if you're in a training situation, setting, attending, supervising, and billing physicians can virtually join virtual encounters, right? So if it's already a telehealth encounter, the attending can come in by video as well. They don't have to be sitting next to the resident or the the rendering provider in that setting. Okay. All right. This one is the tricky one that I mentioned before, or I don't know, it's a little slippery. CMS put this in, recognizing that the flexibilities could potentially go away, and they realized that FQHCs and RHCs would be specifically at risk if the flexibilities go away because they have never in the law, in the telehealth CMS law that Congress passed, FQHCs and RHCs have never been recognized as a valid billing site. They've been a valid patient site, originating site, it's called, where the patient could be there and see some doctor somewhere else, and that doctor could get paid, but the FQHC and RHC could not get paid. Until the pandemic flexibilities, until the PHE, that was the first time FQHCs and RHCs could get paid for telehealth services. And so in the medical domain, CMS said, if those flexibilities go away, here's a back door. Use G2025 for medical telehealth services, and it'll be paid as an average calculated rate of a number of codes. It's going to pay less than an audio-only E&M visit, most likely. I haven't seen a rate, but when they do these calculated rates, they end up being lower. But it'll at least be something that FQHCs can do. And remember, it doesn't affect behavioral health because that's already permanently allowed everywhere, FQHCs and anywhere else. All right. Opioid treatment program initial assessments. CMS weighs in on this because these kinds of treatments kind of get regulated from they get triple teamed on the regulation. CMS regulates them, or at least weighs in. The DEA weighs in, and SAMHSA also weighs in. All of them have regulations about providing controlled substances, Schedule II substances in the context of opioid or various substance use disorder treatments. Specifically, opioid treatment programs are a type of program, a type of service that has a legal definition, and they do most or any program that provides opioid treatment services fits into that definition. And so CMS just said, for its part, opioid treatment programs can still use audio or video, either one, to initiate Suboxone treatment for opioid addiction. Now, if it's methadone, it has to be live video. And this is CMS kind of lining up. SAMHSA has the same set of regulations, and DEA, mostly the same, although DEA has to gussy it up in a bunch of ways. But SAMHSA and CMS are in alignment here on this is what's allowed in these contexts for these kinds of medications. All right. A couple of little housekeeping things they always throw in there. The Q3014, the originating site facility fee, gets set for what it's going to be paid this year, and this year it's $31. That's the site. If you're originating site only, if you're hosting the patient but not the provider is somewhere else, and the provider is getting paid a professional fee or a PPS or AIR rate, then the site where the patient is sitting can also bill for this Q3014 code if they're a valid originating site. Patient's home gets paid at the non-facility rate. This is a change that was made last year. They're just continuing this on. It's a little higher rate than the facility rate, recognizing that there are more costs. There are lots of costs associated with seeing the patient at home, as well as when you're seeing the patient in a facility or in an outpatient facility rather than a facility. The reason it's a little funny, the facility rate is the lower rate because facilities have access to other charges, facility fee charges that they can tack on top. So the facility rate is generally lower, but this allows the patient's home to be paid at the higher non-facility rate. Providers can use their practice address. This was the big thing last year, has settled into being sort of standard now. If you're sitting at home seeing patients, you don't have to put your home address on the billing form. You can put your practice address on the billing form as the distant site location. That's technically where you're located when you're providing services. And then there are some new codes, the Advanced Primary Care Management codes. There's a whole lecture out there. I could provide a whole lecture on the care management codes. Heartland Telehealth Resource Center, our sister TRC in the Kansas, Missouri, Oklahoma region, just did a webinar on that. I recommend it if you're into care management codes, all those monthly based codes. They did a really nice job of talking about those. So now there's another one, the Advanced Primary Care Management Codes, available for FQHCs as a separate outside of their PPS and AIR. In addition, this will get paid, as well as your collaborative care codes, your primary principal care management, your pain control management codes. There's a whole series of codes that can get paid within this class, and they're also not telehealth codes. So the flexibilities don't go away. These are permanent additional codes that are available. I highly recommend looking into them. They're my favorites. They have been for a long time. A lot of flexibilities and decent reimbursement. Then there are some new codes for interprofessional consultation. Physicians could do this. There's a code for interprofessional consultation among physicians. All the non-physicians said, hey, what about us? Give us some love. So CMS added some interprofessional consultation codes for all the folks who don't have a medical degree or don't provide medical services. Again, all these, I just put with patient consent, all these kinds of consultation codes. If you're going to bill the patient has to consent to it. That's just a standard across the board. So remember that when you're doing these things now that don't need the patient in the room, if you're going to bill the patient, they need to know about it. It can't be a surprise. All right, let's talk about DEA. Last few things here. DEA extended, like I said, extended their waivers until the end of this year, until December 31st, 2025. It gets a little confusing, but that waiver is in place right now, and it is more generous than the permanent DEA policies that just went into effect. So we're going to talk about these permanent DEA policies, one of which is permanent, but it's being superseded by a waiver until the end of this year. A little confusing. Another of which is only in the VA, and a third one that is a proposed policy, hasn't even gone into effect yet. So this is a little bit of a mishmash and a little hard to sort out. But the basic thing, unless you're in a VA, DEA policies are the same as they have been, and they will be the same until the end of this year. I suspect there will be some more changes to the permanent policies underneath the waiver while the waiver is operating and in effect. There will still be changes here. We're probably going to see some of that this year. But despite all that, the waiver is still in effect. So all medications scheduled 2 to 5 can be prescribed by telehealth without an in-person evaluation. You need to maintain a DEA registration, but it only has to be in one state, usually your home state if you're one of those physicians. There are lots of, it's going to say in the next few slides, I'm going to talk about special registrations and such. All of that is superseded by these waivers right now. Okay. So in a sense, so the short answer, the short summary is DEA policies are remaining the same till the end of the year. Now, underneath that waiver, the DEA has posted a final rule, supposedly went into effect February, or I think it was extended now until March, but still superseded by waivers. It's more restrictive. It only covers Schedule 3 to 5, so the big ones that you really need are not in there. The narcotics and the stimulants and all of that. The provider, according to these new permanent rules that are not yet in effect. I mean, they're in effect, but they've been superseded until the end of the year. The provider and the pharmacist have to verify patient identity. Provider always had to. Pharmacist now also has to verify the patient identity. The provider has to consult the state PDMP. They have to document that they did it. If it's unavailable, they have to retry. They can only do 7 days, and they have to come back in another 7 days and try again. There's a whole series of documentations they have to make that prove that they consulted their state PDMP. And if the patient's in another state, that they also consulted that state's PDMP, which makes sense. The patient's in that state, but their state and the patient's state, any other state the patient might be in, I mean, it's just like they want a lot of PDMP checking. And they can only prescribe up to 6 months total before they see the patient in person and do an in-person assessment. Okay, that's gonna bite. They could refer to the next provider to do another 6 months. I've heard that talked about. There could be other exceptions that obtain, and so they can, there are various ways that this may change. DEA could change this rule between now and the end of the year too. So stay tuned on this. Fortunately, it doesn't impact you yet, but they're just saying, hey, this is the rule as we see it right now. It's going to go into effect at the end of this year unless we change it. So stay tuned there. The final rule for the VA is only slightly less onerous. VA providers can rely. Oh, well, actually, it has this huge what would you call it? Characteristic that the VA, a benefit for the VA providers, they can rely on any other VA provider to do that initial in-person evaluation. If you're in the VA, some other VA provider has done an in-person assessment with that patient, you can rely on that assessment. You can prescribe controlled substances. So this is how it works within the VA. It seems to be a workable solution here. They also, though, want a lot of PDMP reporting, the VA's PDMP, the state PDMP. They want all those documented. And until they're documented, only a 7-day supply and continuing 7-day supplies until they can access the PDMP. It doesn't apply to specific clinics that are in the community care network. It has to be the regular VA facilities. So that's the rule for the VA. The final proposed rule, this one's the one that's not in effect yet, even though the others also are not quite in effect because they're superseded. But this is the one that we've been waiting for years, since 2008. The special registrations. DEA last year said, we're not going to do those special registrations that Congress told us to do, and then told us again to do. We're not going to do that. This year they say, oh, wait, we misspoke. We are going to do those. and it's 3 levels. The first one is the standard prescribing registration. Again, Schedule 3 to 5. So if you need this, great. But you're probably going to want the advanced telemedicine prescribing registration that includes Schedule 2. It's kind of like the platinum status for the prescriber. This one you can use, you can do Schedule 2 with. However, all kinds of restrictions around this. The patient and the provider have to be located in the same state, for one. And also, the Schedule 2 prescriptions that rely on this registration must be less than half of all a provider's Schedule 2 prescriptions in any month. So every month, if you're going to do 10 telemedicine Schedule 2s, you got to do 10 in person. Needless to say, there's a lot of debate about this. It's still a proposed rule. It could undergo changes. I suspect it will. So stay tuned. There's also a third registration that the DEA came up with. Hey, what about folks who do all their work online? Those platforms need registration as well. So a telemedicine platform, that is, think about Teladoc and American Well and some of these large online prescribing organizations that have their own software platform. They're going to need to register themselves as a platform prescriber. Their providers still need individual registration as well, but the platform in addition needs registration, and then that will allow registered providers to prescribe via the registered platform. So kind of a double belt and suspenders approach there for platforms, telemedicine platforms. The PDMP checks right now are required for any related jurisdiction, but eventually they are saying within 3 years, you're going to have to check a nationwide PDMP. Um, it doesn't exist yet, so people are wondering, how do we do that? Well, DEA says, well, they haven't said anything, but basically they're implying, stay tuned, we'll get there, it'll happen, or the rules will change. But they would like a nationwide PDMP check within 3 years. Also, they are rolling out or propose to roll out a special telemedicine registration in every state. And these prescribers who are going to make use of a special registration are also going to need special registrations in every state that they operate in. But again, we haven't seen what those look like yet. So that's the DEA situation there. It is still, unfortunately, in flux. We're going to have to stay tuned. Um, but that's what we know at this point. Fortunately, right now, we still have waivers in place. We're still operating under those waivers. So we'll see how things change. All right, wrapping up here, just a couple of reminders. You can reach us all the telehealth resource centers at the telehealthresourcecenters.org website. From that place, you can get to all 14 TRCs, including us, gptrack.org. Lots of information, lots of resources there. But again, reach out to us directly. It's a better way to get hold of us. I'm also going to call out CCHP, which is at cchpca.org. They are the Policy Telehealth Resource Center. All kinds of policy resources there. I do commentaries every month. They have news and updates and analysis for all of the telemedicine rules. They have a specific FQHC, a set of resources that are specific to FQHCs also. If you're in that category, it's been something that has been missing for years and years. Last year, they did a special project to implement it. So there is lots of good stuff there to check out. Finally, we provide policy resources, expertise, training, presentations, all kinds of individual consultations. All of that is free. The one thing we charge for is our conference because, there's food and there's a hotel and there's all that stuff. We try and keep it minimal. It's under $400. You can find out more about the conference at gptrack.org/conference. It is the only telehealth focused regional conference. People from all over the region are there, not just our 6-state region, North and South Dakota, Nebraska, Iowa, Wisconsin, and Minnesota, but also joining us this year are the folks from the Heartland Telehealth Resource Center, Missouri, Kansas, and Oklahoma, and the folks from the Upper Midwest Telehealth Resource Center to the east, Michigan, Illinois, Indiana, and Ohio. So all 13 states will be there talking about telehealth, and it's very operationally focused. So for directors, for managers, for staff, folks who are working in telehealth, trying to solve problems, we bring in a bunch of people with a lot of experience to help you think about and solve those problems. So it's coming up in April. Check that out if it's something that could be of value to you. Finally, my contact information. Feel free to reach out. We also gptrack.org, or there's also an email address, gptrack@umn.edu. That's our general email address for questions. All right, that's it. I'm going to stop my share. I'm going to go to the questions and see what we have. What is an FQHC? Federally Qualified Health Center. It's a federal designation, and they have access to enhanced reimbursement because they serve safety net populations that have a large degree of uninsured folks within them. So they have access to extra money, and a bunch of rules, extra regulations they have to follow as well. Are registered dietitians and medical nutrition therapy included in this list of providers? Yes, they were added a couple of years ago now. The services are added, but I don't think they bill individually. I think they bill within a clinic. So they are not Medicare providers per se, but those services can be billed. They have to be billed under a supervising provider who can bill Medicare. Remember, this is just Medicare. So if that's not enough of an answer, follow up with me by email and we'll find out the specific answer for your specific case. All right. That is what we have. Thank you, Tammy. That is what we have. Oops. Are there more? Nope, that's it. All right. Um, that concludes our presentation then. Thank you again, everybody, for joining. This presentation, this recording, will be on our website soon if there are people who missed it. Also, the slides will be going out to everybody who was registered. If you didn't, well, you had to register to get the link, so it'll be coming to you. All those links are live and you can follow them up. Again, thank you very much. Have a good weekend. And please keep in touch. Let us know how we can best serve you in your telehealth program. Thanks very much.